Gallegos, who's going to talk to us about the building future surgeons from residency attending. Dr. Gallegos serves as the chief of cardiac surgery here at CHI Health and Creighton University at the level of an associate professor of surgery. He earned his Bachelor of Science in Bioengineering from the University of California in San Diego, where he also completed his medical degree. There's a few of us who went through UCSD, including Dr. Kinsir. He completed his general surgery residency and surgical infection disease fellowship at the University of Minnesota, where he also completed a PhD in experimental surgery. So he's a Dr. Rob Gallegos, if you will. And in 2008, completed a fellowship in cardiac surgery at the Brigham and Women and Boston Children's and Harvard, and recently had his MBA from the University of Iowa School of Business. His expertise are immense in adult cardiac surgery and cardiovascular surgery, with particular interests in heart disease, heart failure, valvular disease and replacement, and CABG as well. He's a member of many prestigious organizations, including the American College of Surgeons, Society of Thoracic Surgery as well. Since his arrival in 2003, he hired an outstanding team. The team has performed over 800 cardiac procedures. The CUMC Bergen campus has recently received the Isolated CABG Center of Excellence. And then this campus, under his guidance with Dr. Gallegos, has performed the first, second Percival procedure nationwide. And we're in a situation where we can teach and proctor others. So I'm incredibly thankful and grateful for his leadership and for all the efforts that he's brought in. I'm still recovering from the sleepless nights. Kristen Mine can speak in when we're trying to overcome the issues with cardiac surgery, and we came a long way in less than 2 years. Dr. Gallegos, it's a privilege to have you here with us. I'm delighted and honored to introduce you. Look forward to your talk about building future surgeons from residency attending. Thank you.
Thank you for the introduction. I think I'm good. Figured out which one works. And actually, listening to some of the conversations that happened earlier today, maybe this shouldn't be from residents to attending, but again, student doctor through attending, because we've got a lot of different people in the audience, everybody from medical student on up. And it's really about what you can learn from even starting today, not just once you become a resident. So, see if I can slow it down. So one of our explicit kind of goals, educational goals this year, is to focus on professionalism. So my talk today isn't a technical how-to talk. I'd probably put most of you to sleep in terms of cardiac surgery if we went into some nuanced talk about a procedure. So I'm going to instead talk to you about something else, but I still hope that it'll hopefully improve some of your outcomes as you progress through your training. Today, this talk is really about kind of the surgery's invisible curriculum, if you want to say, kind of the daily things that happen without you even knowing they're going on. But these are some of the lessons that actually somewhat determine who thrives, who plateaus, and potentially who might burn out. When you look at the literature, Schanfeld in the Annals actually talked about burnout and moral injury. He thought it was driven less by workload and technical ability and more about loss of autonomy and meaning we really didn't enjoy what we were doing anymore. So the implication here is really kind of an uncomfortable one, in that technical skills alone really don't make for a successful long-term career. So what are we missing, and what do we need to think about? And in my experience, what I've seen is that when problems do finally surface with a surgeon, they're not necessarily typically due to technical abilities, but they're often about judgment or relationships between other people. And importantly, leadership under pressure. What do you do when things aren't going well? So technical expertise, no question, is required, but I would say professionalism should really be considered a core clinical skill and not really something that we just pass on the side. You'll probably notice I'll have a lot of references to movies, TV. I love movies and TVs. I think you'll learn a lot from watching this. Why? It's kind of the art media, if you want to think about it, for today. We used to look at paintings in the past when we didn't have moving pictures. Today, again, I look at the media because I think it is reflective of what happens in our lives when we don't even think about it. But when you do look to the printed press and you look at there's lots written. Teaching medical professionals is a book that I often sometimes refer back to. This was written by Cruz and colleagues, and what it states is that the professional identity is shaped largely through kind of an invisible, implicit curriculum that is going on at the same time as the mandatory, kind of obvious clinical curriculum that we see. So we train residents, students alike for hard cases in a very structured way. We talk about cases, we talk about technique very deliberately. But how do you succeed as a physician in the long term? This really isn't taught so well in the same way. So where do these actual lessons occur? Well, they occur in the ORs, the ICUs, the hallways. These moments where people, even though it may sound a little creepy, but people are watching. They're watching you, they're seeing what you do. They see how you handle pressure. They see how you communicate to others. Whether you own the problems that occur or try to push them off, how you treat other people. It's these behaviors that really help people who are above you or watching you determine whether they trust you, whether they want to be involved with you. And ironically enough, none of this shows up in your necessarily in the op report when you finish the case. But it does really drive autonomy, opportunity, what people will bring you into, what will help you move on to the next step. And ultimately, whether you realize it or not, it's really what develops your reputation, whether it's amongst the nurses or your colleagues, your patients. This is what really drives that. And again, like I said, I love television. So some of you, well, not all of you are very old enough probably to remember the television show ER. Some of us aren't. So Noah Wiley, his character John Carter, kind of represented that typical transition from medical student to resident, and then later on in life into an attending. But much like Carter here, residents trained to focus on the next case, the next rotation, the next evaluation that they get. What we rarely see, though, is the kind of the full arc of the total career in terms of what's happening. And again, like I said, I love television because actors tend to do what they do well. So if you're watching the new series, The Pit, with the same actor playing now a more mature Dr. Roby, you see how his responses in attending are. Now, like I said, I love movies, and not this isn't really just an anecdote, but it's really to emphasize that people change throughout life. And in regards the captain of the ship, which I'd recommend reading at some point, it contends really that professional identity forms early and it's shaped less by metrics and more by the culture, feeling of belonging, the role modeling that you do as you see, again, sitting here as students or residents, how you model yourself after other attendings that you see. And really, this begins to matter a lot because as surgeons, we assume that our advancement is purely relates to what we do. I earned it. But in reality, there are factors that accumulate over time. It's kind of unavoidable in surgery where everything we do, if we don't do things correctly, adds up. We can see small errors turn into that snowball effect that ultimately translates down the road to a major complication. And how we handle those complications really is going to be how people look at us. So early in your training, no question, anybody will tell you that your progress is measured based on what your hands can do. In fact, we use that comment, does he have good hands? Does she have good hands? Can she do the job? But as you advance, this benchmark is important, but it stops being really the whole job. Your professional identity, it has to shift away from what is your technical ability to how do you function well in this practice. It's a difficult transition. It's not very well supported, I have to admit, because we focus so much again on training you to operate and much less on how do you practice as a physician. And again, it's necessary for every surgeon. It's not just necessary for those who want to go into academic medicine, meaning those who are gunning for that next role as the chief of the department or head of research. It has to do with every physician, no matter where you practice, whether it's in academics or in the community setting. And literature and lived experience will suggest that surgeons, if you don't adapt to that transition of where you go from technical skills to social skills and social success, but this is where you will either stall or in the long term, really feel dissatisfied with what you do as a surgeon. So again, it's by the time you're attending, outcomes depend less realistically on your individual technical skills and more on your ability to design systems around you. How do you take care of these patients? How do you work with your office? How do you shape the culture of your environment to make sure that the team is successful? So meaning that your patient ultimately gets from clinic visit all the way through their operation and back, and everybody they touch does such a great job that you look like a rock star. And I would say this is a very difficult thing to balance because again, we're trained so much to focus on what do I need to do, what do I need to do, what do I need to do, and we forget about the people around us who are helping work with us. So we think the scale is tipped in this way, where it's us and everybody else, even though there's so many more of our team members than just us. We have to remember that we are a team. I would say that one of the most common early mistakes is confusing autonomy with readiness. Operating independently, first time you got a chance to do the operation where nobody else is watching you. It's kind of a palpable moment. It's a huge milestone. But is that truly complete readiness? Or is it just simply you operating alone? You have to remember that it's not just the operation that you're doing, it's how you handle the entire patient. How ready are you to get people on board if things go wrong? And this is that kind of difference between just being the person who can do the operation versus the person who can take care of the entire patient. Because it's not just about what you do in the operating room, it's about everything that we do from that first introduction to the patient, taking them to the operating room, and managing them through sometimes complications. How you behave around that patient in total. So Gifari, in this lovely paper here, suggests that there's a point where differences in surgical mortality are very important. It's not just, again, about what you did in the operating room, but it's often about failures to rescue more so than the complication itself. So why does he say this? What he says is one of the issues is the failure to recognize the deterioration early and respond effectively is one of the most key points that we fail at. So what he's trying to get across really is that excellence in the operating room, meaning that first case that you did, everything went perfect, but the patient still had a complication. It's not that you didn't do it right, but it's that you failed to recognize the complication that sometimes matters. And it really is important that we do things to make sure that we can recognize this as quick as possible. Because I think cardiac surgery, let's see, sorry, my slide went too fast. And now they're going backwards. There we go. Touchy. Well, I was about to say cardiac surgery is probably one of the most easy places, and my partners will tell you, you can do a perfect case, but things can go bad very quickly. And sometimes it's the most subtle hint. In the case earlier we heard about M&M, that sudden abdominal pain. It may not have been that. It might have been sudden tachycardia that was unexplained, but to make you think of this could be a hernia, this could be a leak. Well, in cardiac surgery, it's the same thing. If you don't recognize that bleeding suddenly stopped and that your chest tubes are now clotted off, you might not recognize an emergency situation we call tamponade. And that patient, if you didn't react rapidly, may not be with us tomorrow. So it's really important that you encourage all those around you to be open, to be able to recognize these early warnings, and that you develop a culture that allows people to bring these to you early so that you recognize these in a hurry and can deal with them as soon as possible. Now, I think if I asked everybody in the room, do they recall that one surgeon who everybody said was the absolute rock star? Everybody thought they were the best surgeon. Everybody in the operating room would say, oh yeah, he's the best. The question is technical brilliance enough? It's certainly seductive. We think of, we admire these people. We think they're the best. We want to be that person. But brilliance without trust is a very fragile thing. The paper here, Cooper and his colleagues asked a very simple question, is putting it in a patient safety perspective. He asked basically, looking at trauma services, they went back and they asked the simple question. If a patient was cared for by a team that demonstrated very unprofessional behaviors, were these patients more likely to have a complication than those that were taken care of by a team that didn't exhibit these same behaviors? And what they found was very much the case. And the question is why? Well, professionalism, especially respectful behavior, is important because clear communication helps recognize these early problems, allows people to speak up, makes it so the team values you and trusts you. If they don't trust you, the likelihood of them coming to you early and speaking to you goes down. And this is where we miss the boat. That we think that just because we think we know it all, if we don't create an environment where people can speak up, well, unfortunately, what happens is we don't know it all because somebody who recognizes the problem may not speak up. So I'll give you a little bit of this kind of slide. Remind me to slow down sometimes. I speak too fast and makes me slow down just to make some people think a little bit about things. But ask yourself, as a student, as a resident, as an attending, we all know that if you go into the hospital in the middle of the night, the nurses will talk about who they want to call at night because there's always the one doctor they know that will come help them, that will listen to them and help the problem. There's also, unfortunately, a lot of doctors they don't want to call and they won't call because they're afraid if I call them, I'm gonna get chewing out, may not get the help I need, and I'm gonna get yelled at. And so ask yourself, what is this? What does it reveal? It tells us that trust is built through reliability, composure, respectful responses under stress, in particular. And kind of the take-home point is that skills might get you in the door, but it's that reliability and professionalism that actually determines your trajectory. Will those nurses get you involved? Will you help prevent the complication or attack it early? Or will you be known as the one who has so many complications your patients don't do well? So hierarchy in surgery, no question, is difficult to avoid. It does have some predictable downsides. It suppresses a lot of critical information, the same stuff that I'm starting to talk about here. Early warning signs that are subtle are usually noticed by people who tend to be at the lowest point in that hierarchy. And something called the authority gradient, if this is way too steep, these people don't speak, those soft signals don't make it all the way up to the top. So silence, as I mentioned earlier, silence is not safety. So if you see something, you should be able to say something. When you think of a quiet operating room, it might look efficient, but what it may be hiding is that people are so afraid to talk, they don't talk, and these problems are festering. So you may get it to the point where somebody won't say, I think you took a bad stitch, or I think you left the defect in that mesentery, and maybe this is what happened down the road. So when you look at the work in psychological safety, Edmondson's work is pretty important. It really kind of brings home this point that when people, when they believe they can speak up, question, admit uncertainty, particularly without embarrassment or the potential for punishment, this is where psychological safety begins. This is what turns all of your team into that early warning system, and concerns can get addressed a lot earlier and hopefully with better outcomes. And as leaders, we own kind of this psychological safety training, but we're all leaders. Again, you don't think of yourself as a leader, as a student, as a resident, but each one of us, with every interaction, is one of these leaders. And these habits that you're learning now are going to be the same habits you continue into the future. So learn them well now, because think of you. I challenge you. Think of these responses to how you train people in your operating rooms. If you dismiss them or you're sarcastic, what is their response? Versus if you invite them to speak up, how do they feel? If you provide a safe spot. So that's what I tell you every day when you're thinking about these questions. Ask yourself, kind of, what am I missing, and can I say this to my team? And do they feel comfortable to say something? But most importantly, when they do say something, you should legitimately and genuinely respond to them. Thank you, because remember, again, they're helping you. They didn't have to, but it's you who creates that space, and it's you who hopefully allows them to it. But again, acknowledge them, because again, this is what continues to build that psychological safety situation. Again, like I said, I have a few stopping points to slow myself down often, but I do this. It's just to remind me, it's drive points home. That ego that we all think we develop, and because we finally made it through all of our training, and I'm no longer the intern, I'm now the chief. That ego can unfortunately get in our way sometimes, and it can lead to error recognition is being delayed. Defensiveness, again, if you make a mistake, own it. But if you're defensive, this actually can block learning. It can block those early warning signals from coming up to you. And like I said, silence to me is harm. I think people, if you see something, you should be able to say something. Otherwise, again, no matter what the situation is, it's gonna cause you problems. And speaking of problems, I would say there isn't one of us who would tell you as a attending that we've never had a complication. And adverse events are going to happen no matter what we do. We, in general, I think as humans, we try to look for that one person, that one moment, that one event that was the cause. And we think this, if I can only stop that one person from doing this one thing, this would never happen. Reality is that's probably not true. What we see is that usually to get to that complication, there was a series of events that had to go exactly the wrong way for it all to happen. Now, when you look at this, James Reason has a famous model, the Swiss cheese model, that really talks to us about how we have to align all the holes for everything to happen so that the patient can fall through all the safety pathways that should have been there, should have been present, whether it was protocols, the number of people rounding on the patient, the nurses looking out for them, reactions to people falling off protocol. But you might recognize this in a different form, though. We presented it almost every M&M. We think of it as a fishbone diagram. In this case, we align the fishbone and it falls on that line. But what you forget is that these holes are shifting around. So, again, I think the Swiss cheese model actually kind of brings it a little bit home. What it tells you is that all of these factors have to perfectly align. If we can get those to shift away, maybe we can actually get that patient not to have that complication. So it's important to think of these things. It's an error to say it's that one person. But again, unfortunately, that's what we tend to do. We tend to try to point blame. So really, what we really should try to do is reframe this question. And as an effective leader, the goal shouldn't be to assign blame to a problem, to a situation. It should be to strengthen the system. I think most people will I say this often, it wasn't one person who caused the problem. I don't need to know which nurse didn't do this or that, because it's a system problem. Because if this nurse is doing it, or if that doctor is doing this, it's likely that many others are doing the same. So if we find the problem, if we can identify that system problem and correct it, we can hopefully prevent future patients from having the same. And I would say, again, I bring it back to M&M, because I think M&M, if it's done correctly, and I think ours is done very well, it creates an environment of safety where each event should be looked at as a learning event. And as a student, you should learn from your attending's mistakes, so to speak, because these are the best times. They're kind of free lessons. You can see what happened, how that attending responded to the situation, and hopefully, again, you can skip that step and not be up here at M&M discussing your patient. But again, unfortunately, as I go back to the beginning, complications happen. None of us will get away from them. I'll take you back to art, because I like the series The Pit. I don't know if you guys have seen it, but it's a great show to watch. The first season's done. The second one is just beginning. Gives me something to do. Well, again, like I said, in surgery, failure is inherent. Every surgeon will face that complication, near miss, lapses in judgment. The question in the end is, when you encounter it, what are you going to do? Because we all are going to encounter it. The line between growth and derailment in your career really becomes the question of, do you become defensive and withdraw, or do you lean into the problem and learn from each of the situations? And again, I think this is what M&M helps us do. In the, can't really see the paper here, and I didn't really pull up the abstract, but Wu underscores that transparency and error matters. It's important, not just to the patient, to go in and be able to tell the patient, look, we did this procedure, this happened, this is a complication, this is an error. It matters not only to the patient, but to the rest of the team and how you model your behavior. If you can go in and talk to your patient in front of your team and tell them, this is a problem, this is what we did, this is what we need to do to help get you along the way. What it does is it acknowledges that as a surgeon leader, you can make errors, but more importantly, that you're willing to own those errors and move forward. and try to help the patient. Not doing this, silence minimizes or shifting the blame to another person. You know, it may feel somewhat protective and may make you feel a little better in the moment, but what you don't realize is it steadily erodes your credibility as a surgeon. So you don't necessarily want to be known as the guy who has complications all the time, but you do want to be known as the person when they do have those complications. They own them, they help the patient through them, and they help the team through them. And realistically, credibility is not an easy thing to restore once it's lost. It can't be restored with a single apology. You can't just go and say, I'm sorry, I'll never do this again. Because if it keeps happening, people will see. People will build their own beliefs of what your credibility is. Heading towards the end of things, but when we think of burnout and moral injury, we really think of it as more of a sense of doing something against what our beliefs are. Burnout, I'm just sick of this. What's the difference between the two? Really, in the end, burnout, I think, is driven again by this lack of enthusiasm to go into work. So again, you sit here as a student and you want to look down across the room and see your senior surgeons. You see them happy. You want to be that person. It's really important that you recognize this this difference. This distinction really matters. It really helps you distinguish the difference between your own abilities and the system abilities. As surgeons, we all expect to work hard, but this notion of coming into work when you really can't stand it is really what's going to force you out of this profession, or make it so you don't enjoy doing this profession. If you don't enjoy doing the profession, how well are you going to perform in the long run? So to me, as I mentioned, this is the long game. You look at the senior folks in the room and you ask yourself, how did we get from student to resident to attending? We're all lifelong learners, really. We think of getting to attendinghood as kind of the end goal. But what we don't realize is this is not really the end of the game. This is just the start. It's the beginning of a long career. So you haven't crossed the finish line yet, really. This is the point where your reputation starts to begin to develop. Your sense of meaning in terms of what you're going to do begins to be shaped. And it's not what you do at that single moment that you become attending, it's what you continue to do that really is going to kind of shape who you become and how satisfied you are in the long term. And, again, I'll go back and ask the simple question of everybody in the room. Who here has worked with that attending who was technically gifted, but difficult to work with? What happened to them in the long run, to their practice? Well, pattern isn't usually necessarily that dramatic. You don't see them being dragged out of the hospital, but what you see is that people stop volunteering to help them. Communication starts to get a little filtered. They don't call you. Number of consults starts to decrease because people don't necessarily want to work with you. So nurses certainly hesitate to call you. And ultimately, your referrals may soften or go away. It isn't because you lost your technical ability, but it's become too expensive to work with you from that sense. Nobody wants to invest in you anymore, so to speak. So yes, your practice might continue for a while, but it starts to narrow. And I think this is where that surgeon becomes even more and more isolated, and it happens at a point when they actually need the team the most, but they've pushed their team away. So the goal here is to help you try to build that team. So, as I conclude today, I'll do a little early, get you guys going through things. But I guess I'll hammer a few points. Technical excellence, no question in my mind, is required. If you don't have that, trying to be successful as a surgeon is going to be difficult. But this isn't the only currency that you have to work with in your practice. The long game really is played with reliability, professionalism, and the relationships that you develop, especially under stress. So as I close, I'd like to carry forward. It's not how do I become attending, because each of you will become an attending. It's more the question of what kind of attending do I want to become? And think about it, these pretty easy question. You think about the attending that you see in front of you, the ones you want to model after. who is it you want to become? But more importantly, years pass before you know it, you'll be up here looking down at the students and asking the question, probably a more important question, what kind of attending do I want the students who are sitting in that chair making of you guys? So again, like I said, this is a journey. It starts from where you are, and we move on. But in the end, that's what I would always tell you in terms of legacy is what kind of person do I want to be remembered as? So finished a little early. I have a tendency to talk too fast. So now I'll open it up to questions. And I'll warn you, if you don't have questions, I have questions.
Thank you, Dr. Gallegos. I really appreciate you sharing your insights on an important topic and shedding light on the importance of professionalism in the workplace. It's a journey. Questions for Dr. Gallegos from the room or on Zoom? Dr. Penis, good to see you.
Thank you very much. It was a fantastic talk. I took a lot of notes as you were talking. It was just wonderfully presented. Do you have a structured approach that you recommend for trainees to audit meaning? It was a fantastic slide when you said, meaning preserves careers. And I wonder if, how can people identify what energizes them and design a practice pattern around it? Thank you.
I think it's an excellent question. I wish I had the absolute answer because I would say that's when I look at our training in medicine, there are some major gaps. We think about the technical. Do we know the medicine behind it? Do we know the science behind it? Unfortunately, I look at my wife is in business, and I would tell you that we should probably take a lesson from other specialties. They actually teach them more about how do you work with people. And again, the other aspect of what we don't train our students about is the business aspect. We don't train them how do we that first contract that you get as an attending, how do I read this? So those are I think the two major gaps that I think that exist in our training, and it's something that I think we should try to focus on. I wish I had an absolute answer to you there. I can tell you the way I did it. I as a student, I would again look to my senior surgeons and again, like I said, people are watching. I'd observe them. I'd see how they behave. You could see them in the operating room, amazing hands, but then you see them, they would be the people that would avoid talking to families. They're like, I don't want to talk to families. DeBakey is famous for that. He had an elevator installed in his hospital, and when I say his hospital, he actually owned the hospital. Elevator that went from his office to the operating room, so he specifically did not have to talk to patients and their family. You think of these people as giants, but unfortunately, these are kind of the behaviors that you would say are not good for people. So about the best answer I can tell you is I learned from looking and observing at others in terms of what they did badly so that I could try to avoid it. I learned probably more from that than necessarily seeing people who performed well. I think people who perform well do a wonderful job, and patients and families love them, nurses love them. Those are what you strive for, but oftentimes it's about learning what you shouldn't do.
Dr. Rosa.
Thank you for that wonderful talk. A lot of times we talk about like the 3 A's to be a successful surgeon, right? So affable, available, able. And I think almost everybody leaves able, right? I mean, they would be leaving the residency. And what we're really talking about when we talk about professionalism is that affable part. When Dr. Castling and I went to the ACGME training program about giving feedback, I think one of the hardest areas to give people solid critical feedback is in this professionalism category because it feels so personal. Do you have any tricks or tips or advice for how, besides modeling the behavior, that we can help to mold our students and our residents, giving them like critical feedback, but acceptable feedback?
I think I would say you hit it right the nail on the head. It's feedback is the critical piece. What we need to do is create a space where feedback is viewed as acceptable. You know, we think of feedback as I'm going to tell the student what they did poorly and bad or did well. What we forget is in order to create that safe space, you actually have to be willing to accept feedback too. And I think the way I tried to lead with it sometimes is asking literally that same question of, hey, how do you think we did today? How did I do today? Is there something that I did or could do better to help you? And it's amazing how that it's kind of that icebreaker where it suddenly opens them up to being able to, if you're willing to get feedback from them, they become a little bit more willing to receive feedback. Otherwise, it becomes a little bit more dogmatic. You're telling them what they did right or wrong. It's not really about opening that space to make it safe. So that would be my best advice, because I think feedback is important. And I hate negative feedback, but on the other end of it, if I don't know what I'm doing wrong, I think I'm going to keep doing it, right? Because I think I'm doing something right. Until somebody tells me, really, you know, I don't like the way you said that, or this offended me, you may not even realize it. You may keep doing it. So that's what I would say is begin by, in terms of feedback, opening it up to your students and saying, you know, asking them first, how did I do? You know, did I help you in this? You watched an operation today. Is there something I could have done to make that experience better for you? And then being open to actually listening to it, because if they tell you, boy, you didn't explain the thing to me, you did it, I was supposed to watch. I remember one of my favorite attendings in fellowships. That was his point of teaching. You were supposed to watch him and learn from what he did. He never said a word to you about why he did it or how he did it. It was just watch me and learn. You know, and finally one day I did tell him that. I said, you know, it would be a lot easier if I understood the why behind it. And he looked at me and said, basically, well, you should know the why. I mean, it's hard to know the why if it's not made explicit. So I would say be open to receiving and giving feedback, but most importantly, the receiving part is the important piece. It opens the door.
Wonderful talk. Two questions. One, what are some red flags that a surgeon should make them concerned that they're falling into this negative feedback loop? Things they should look out for, aside from what you've already said. And then my second question is, as a senior leader, what is your strategy to try and rehabilitate somebody that, you know, in your department or your colleague that you are concerned about? Like, how do you get them out of this like destructive pattern?
Yeah, the red flags are hard because you know, in general, I think as we don't like to necessarily, you know, you find it, people fall into one of two categories. Either they like to talk about everybody, and that might be assumed as being more gossip than anything else, or more likely we just don't talk about it. So those red flags are sometimes hard. Uh, it's easy when you get a series of reports from that this person is doing this or not doing this. You can then approach that person, and again, I would start with the second part of your question. The most important thing is to ask them, how do they think they're performing? Because again, in general, I think most of us think we're doing a great job, and we may be unaware of things we're doing. So you start there and you ask them, how are you doing? Are there things that aren't going well? There's some place that I can help you. So it's a difficult place. You do have to keep your eyes open. But as that person, if it's you, you should start asking the same question. If there's a lot of people who you initially worked really well with who suddenly have backed away or don't want to be involved with you, you might be doing something wrong. It might not just be that, oh, I haven't seen them in a while. If they actively avoid you, there's a problem, probably. And again, those are difficult things to approach, but it's probably best in the point where you're not in the heat of the moment, the problem is happening. Go back and find that person, you know, whether it's a week or so later, and say, hey, you know, can we talk? This happened. You don't seem to be talking to me too much. Is there something I did that was wrong? If you start with you did this wrong, you've pretty much lost them. It's really most important is to try to get that information. So, as that individual, if you feel like you're falling through the track, that's where you should start. And then again, go to your seniors and ask, if you're an intern, go to your second, third year. If you're that second, third year, go to your chief. If you're the chief, go to your attendings and ask them, I'm doing this. I don't seem to be getting the response I'm hoping to get. Do you have advice?
Other questions for Dr. Gallegos? Dr. Pepinos?
I'm interested in your thoughts on how do you distinguish burnout from moral injury, and are there any signs that tell you that it's primarily system-driven misalignment rather than overload?
Yeah, it can be a blurry line. I think burnout is often really somebody who just doesn't want to show up anymore, who's just seems to be exhausted, is more withdrawn, doesn't want to be doing things anymore. Whereas moral injury, I think, is you've seen it. You're as an attending, you're like, boy, I hate it when administration does this. I hate when they move this meeting. You're still willing to fight, so to speak, and it's showing that you don't like what's going on. When they tell you, we're not primary care doctors where they tell us, well, I want you to take your daily clinic schedule from 30 patients to 50 patients. When you start to say you're trying to force me to rush on my patients. But as surgeons, we see it in the same way when they start telling you, well, this suture is as good as this suture, but it costs a lot less. And then you tell them, well, it's not really the case. These sutures break. I think moral injury is when they force you to do that and you continue to try to fight back. Burnout in general is people just are done. They don't want to show up. They don't participate as much. They don't really try to help the rest of the team quite as much. But it is a very difficult thing to really kind of distinguish between the two because they can overlap.
Dr. Gallegos, I'm listening to a podcast on the laws of human nature, and narcissism comes in a lot, which surgery sometimes attracts that. And so thoughts, because as you can imagine, gift to surgeon at times, narcissism is excessive self-love with lack of empathy.
I think, and unfortunately, our specialty, I think, tends to gravitate towards individuals like this. It actually seeks these people out. Oftentimes, when you think about everything that we did in training, how you were selected to go from undergraduate to medical school to residency to fellowship and beyond, it's a difficult thing because I think a lot of what we do in this profession chooses those people. I think so. As leaders, I think we do have to actively, every time we look to advance somebody, we do have to ask these questions of, are they doing it for the right reasons or are they doing it for themselves? And I think that's when I look at anybody that when I'm asking myself, do I want to work with them? That's really the question I'm asking. What is their reason for doing what they do? If it's truly self-love versus they really want to actually help their communities, their patients. I think that's the difference. We've cardiac surgeons are the worst. I think there was again another famous movie who surgeons on the stand and they ask him, "Do you think you're God?" He says, "I don't think I'm God. I know I'm God." That's absolute narcissism. And I think again, like I said, it's the natural tendency of how we select individuals to move through this process. But unfortunately, once you're there, you really have to again how do you develop your own team? You may not want that individual on your team because yes, they may be the rock star, but are they going to be the best team for you? Goes right back to the same question that again from Michigan, which of those team members do you want on your team? It may be that person out in C who had only the two skills, they were the best two skills, but is that individual somebody you want on your team? May not be.
Thank you. Are there thoughts or comments? And to Dr. Hayes' point, one of the to me the red flags in recruitments, we focus a lot on the behavioral standard questions when we're interviewing candidates, and one of the questions that I like to ask is, tell me about your blind spots, or if we call 10 people who know you very well, what opportunities for improvement? And if the answer is none, or I don't, or they evade it. That I'm increasingly using that as a screening mechanism, but this is not going to be a good fit.
In a similar way, I always ask the same question. If your person you love the most needed the same operation you perform, who would you call? And if their answer is me, you got a problem. You know, they can't recognize that there's anybody else in the specialty that could do the job as well as they can. You gotta, you know, this is somebody that you might want to pass on.
Ethically, it's a problem as well.
Yeah.
Yeah. Other questions? Any questions from Zoom? Dr. Patel, thoughts from the PD standpoint?
I mean, I think this was a absolutely fantastic lecture. I think that these are questions and issues that, especially I think early in your training, can feel a bit abstract. During the interview season, a question that a lot of applicants ask me is, what should I do to prepare for residency? Medical students ask me that all the time. My first piece of advice is, maybe a little bit off the beat track. So one, don't worry about preparing for residency. You've done that for 4 years in medical school. Enjoy the last summer that you're going to have 2 months off in your life. But two, I think that this is advice I also try to give the residents as well. The pathway, especially if you follow a very traditional route to becoming a surgeon, is very straightforward and has very defined objectives. You go to undergrad, you do your prerequisites, you go to medical school, you pass some exams. You pass some more exams, you become a resident, you continue to pass exams, and that's it. Now it's not clear where you go from there. And I think that what's really valuable, and I think it really alludes to, finding meaning in what you do, is taking time to reflect, especially early in your career, which includes when you're a student and when you're a resident, about where you're going and what that looks like and what is valuable to you. And I think, the question I would have is, what advice do you have for residents? I think especially because it's very busy. I think that the training paradigm has changed. 80 hours is still a lot of work during a week. And it's very easy to get caught up in the day-to-day grind of what you're doing. You're pulled in so many different directions, technical proficiency, you need to read, you need to do X, you need to do Y and Z. It's really, I think, a challenge to step back and figure out, what do I want? What is this going to look like for me? Not just in 5 years. I think that question is usually easy. I want to graduate, I want to get a job, I want to get a fellowship. It's what does it look like in 10 years, 15 years, 20 years? And I think that is a question that maybe your perspective changes over time. If you have advice on how to approach that, especially earlier in your training. One of the questions that was buried in here that I didn't ask is that, in fact, I almost went verbatim in the sense of 10, 20, 30 years out. Where do you see yourself? And the problem, I think, I trained in the paradigm before the 80-hour work week, and when came out at a lab after I finished my PhD with the 80-hour work week, now in the full section, I didn't really notice the difference, to be honest. And I think it's partly because I think the pathway I chose was, I always asked myself, what do I want? Not what am I told. And that was what I would tell you, is enjoy life. The same advice you gave them, not to worry about residency. You have to stop and sit back and ask yourself, every day that we're doing this, why am I doing it? Work to live, live to work. You have to ask yourself, who am I? What do I want to be? And I'm not talking about your professional life. I'm talking about your personal life. You always have to ask yourself, when I look back, and I'll say it was the last comment I made, is what do I want people to remember me? What is my legacy? I don't want my family, my kids to say, oh yeah, he was the best cardiac surgeon out there. I want them to say he was the best dad, or the best husband, best person. So I would tell you, find what you enjoy, do that alongside what we're doing here professionally, because again, your professional identity is just one identity. If you don't have your personal identity in terms of who you are, what matters, it's going to be difficult to want to show up the next day to work. Because if all you are work, we will fail. I said, we will have complications. And if you identify yourself only as your profession, ultimately, we're going to have failures and you're going to feel like you failed. So I would tell you, if you can identify what you enjoy, who you are, enjoy that life, and come and do your work, you'll probably come in happier, want to do better at your job, and leave happier, and want to do this for hopefully longer. But again, I've worked with surgeons who at 76 are still operating.
And I look at them and I realize this is who they are. They don't have anything outside of this job. And I'll tell you, they are probably some of the most unhappy people I ever met, even though they were fantastic at what they did. Why? They didn't have things outside of life, outside of that life. So I go right back to what you said, which is don't worry about residency. It will happen. Same way I'll tell you, don't worry about attending ship. It will happen. You will become an attending. But who you are as a person outside, if you develop that person will come in and be a good person when they're an attending. That's what you really need to be, is focusing on being a good person, listening to people. I talk about feedback, and my wife will remind me that I probably need to, follow what I preach and actually listen to her feedback. Still failing there a little bit, but again, I would tell you, enjoy what you do outside of work, and you'll probably enjoy what you do at work even more.
Dr. Gallegos, thank you so much. This was an excellent ground rounds. I really appreciate it. And it's going to be video recorded for those who want to watch it again and learn. I'm certainly going to do that. We're truly honored and blessed to have you in our team. So is your cardiac surgery team. Let's give Dr. Gallegos a round of applause. Thank you.